Okay, today we're going to talk about evidence-based health screenings. Hopefully you've already read the chapter in your book and you're ready to kind of learn a little bit more about it. So first I'm going to talk about testing. So there's a couple reasons why we test patients. One is we want a diagnosis, so we do a diagnostic test. The other one is a screening test because we want to see if an asymptomatic patient might have a disease that they don't have symptoms for right now. So if somebody comes up with a positive screening test, well then we would of course order diagnostic tests to make sure that it's really the definitive diagnosis. But today we're going to talk really about screening. So what do the test results mean? And I know sometimes this can be confusing. And you might notice in clinical that people order a lot of tests all the time, but the thing is you really want to know a little bit more about the test that you're using. So for screening, we want to know about the sensitivity, the specificity, the reliability, and the predictive values and prevalence. So some common screenings would be like a pap smear. You might see that done, mammograms, colonoscopies, bone density tests, blood pressure, fasting blood glucose. These are things that you're going to see commonly in your clinical settings. But one thing we found out, that screenings change. So when I graduated 2003, prostate cancer screenings were very popular. Patients that were over men, of course, that were over 45 were given a digital rectal exam along with a PSA. And what they found out that there were a lot of false positive results, approximately 80%. That's really high. So what would happen is we were getting a lot of men that not only were scared because they were told that it was positive, but they were put through biopsies and some other procedures that were perhaps not necessary. So now the United States Preventive Task Force recommends against it. So if you still see it in clinical practice, you might want to ask your provider why they do it. There are incidences where you should still perform it, but you want to talk with your preceptor and just see like why they're still doing that. So that's changed. And men are very happy, I'm sure, that it's changed. And then, of course, pap smears. Back in 2003, a pap smear was done on every woman or every girl that was sexually active. So say you were 12 when you first started having sex. At 13, within 1 year of sexual activity, you were to have a pap smear. So we got a lot of false positive pap smears, and young girls were put through colposcopies and biopsies and things that really weren't necessary. So after a lot of research was done, they found out that really women do not need a pap smear before the age of 21, no matter what their sexual activity is. So let's talk first about the sensitivity of a test. So the sensitivity is the ability of the test to identify correctly those who have the disease. So if you look in page 19 in your textbook, there's a table 3.2, and you'll kind of see there's a little bit of a diagram there about how we tell whether or not a test is sensitive or specific and how reliable it is. And I'm going to have a little YouTube video a little bit later to kind of explain this a little bit better. So I'm going to give you an example of an ANA, which is probably more of a diagnostic test than a screening test. But anyway, I might go over it anyway. So the ANA test is especially helpful in diagnosing lupus. So more than 95% of people with lupus will test positive. However, not everyone that tests positive for ANA will have lupus. So sometimes it can be a little bit confusing. And in fact, up to 15% of people who are completely healthy will test positive. And this would be called a false positive test. So specificity, which is not always easy to say, is the ability of the test to identify correctly those who do not have the disease, which is different than sensitivity, who's going to be able to identify those who do have the disease. So a highly specific test will produce very few false positive results. So it's really important to know the specificity and the sensitivity of the tests that you're ordering. So with predictive values, you have positive predictive values, which is a proportion of patients who test positive who actually have the disease. And you'll notice that you'll see that in your diagram, your table on page 19. And then there's negative predictive values, which is a proportion of patients who test negative who are actually free of the disease. So here's a YouTube video. I'm going to attempt to play it. Hopefully you're going to be able to see it on your screen.
Hello and welcome back to this Global Health YouTube.
This guy likes to smile a lot, which is okay.
The epidemiology playlist. We've got other playlists, of course, and I want you to go to the YouTube channel, have a look at what we've got, subscribe if you haven't, and you'll get an email alert whenever there's a new video posted. So if we've got a diagnosis this case those encircled in red, are the true negatives. So here we're saying 827 of the 830 will correctly test negative. So 827 over 830 is 0.99, which is 99%. So of people who don't have the disease, 99% of them will be correctly identified by this test. So I'm not going to go through all the calculations again for positive and negative predictive value. Basically, the exact same principle applies. The positive predictive value is the proportion of people who test positive who actually are positive. So the positive predictive value tells me if I go for a test and I test positive, what are the chances that I actually have the disease? Now, there's an important difference between sensitivity and specificity and positive and negative predictive values, and I need to explain this to you. When we look at the sensitivity test, for example, everybody in the green circle actually has the disease. And so the difference between the numerator and the denominator, the numerator being the 66 people and the denominator being the 66 plus 4, so the 70 people, the difference between those two groups is a function of the characteristics of the test itself, and it's not affected at all by the prevalence of the disease because everybody in that group has the disease. In other words, it doesn't matter if it's a common disease or not, because at that point in time, everybody that we're looking at actually has the disease. Now, this is not the case for positive and negative predictive values, because when we're looking at a positive or negative predictive value, the difference between the denominator and the numerator is affected by the prevalence of the disease in the community. And so it's not simply a function of the characteristic of the test itself. Now, this is still a useful test, but you need to remember that when you're comparing one test with another, in terms of the positive and negative predictive value, you need to be looking at the same population group, or at least population groups with the same incidence of disease. Okay, that's all from me today. I hope you enjoyed this video. I hope it was helpful. Remember to subscribe to the channel. Remember to make comments.
So hopefully that kind of explained it a little bit better so that you can really understand why you order certain tests. So next thing is reliability. Reliability can be kind of hard with testing. So if you think of reliability, you think that's a test that can be repeated over and over and over again, and you'll get the same results. You'll be able to reproduce the same results every time. Those tests are hard to find. So you have laboratory procedures, you have somebody who's observing it who's maybe not doing it wrong, not doing it right, somebody who's maybe doing it incorrectly. I'm thinking of more of blood pressure measurements, or there's changing conditions like time, location, weather, humidity, things like that. So with reliability, the data may be imprecise or inaccurate, and it may not be suitable for diagnosing. So let's take, for example, blood pressure measurement. So you have a patient come in, your MA slaps on a blood pressure cuff, presses a button, and voila, you get a blood pressure, and it says 160 over 92, and the patient's like, oh my goodness, my blood pressure's never been that high. So the MA writes it down, and you come in and you're like, oh my goodness, it looks like this patient has high blood pressure. However, you repeat it, and you make sure that the arm is at heart level, and you find out the blood pressure is really 130 over 72. So the test is not really that reliable unless you do it the right way and you do it the same way every time. So that's just one example. So if nothing else, I want you to take away from this short lecture that you need to treat the patient, not the test results. So as you know, there's no test that is 100% sensitive or 100% specific or 100% reliable. So you need to make sure that you look at the whole picture, you look at the patient. If you get a test result back and you're just like, oh, that just doesn't seem right, don't be afraid to repeat the test result, ask them to repeat it, or have the patient come in and have another lab drawn and repeat it again maybe a couple days later. So here's my reference that I used a lot of my slides from, and hopefully you enjoyed this and it makes sense to you.